All right, well, thank you very much, Dr. Douglas. I have no relevant disclosures for this presentation. I'm going to be focusing mainly on echo reimbursement under the CMS physician fee schedule, since that's what we actually have the most control over, both historically and I think going forward as well. We'll start just with a little historical perspective. A little over 50 years ago, President Johnson took a trip to the Harry S. Truman Presidential Library in Independence, Missouri. The purpose of that trip was to sign the 1965 Medicare Amendment to the Social Security Act. And that was pretty important because at the time, over 50% of Americans over the age of 65 had absolutely no health insurance, and many of them were actually living in poverty. You can see here that he returned to the library several months later, and he's here giving the first two Medicare cards to President and the former First Lady, President Truman and the former First Lady. You can see there that the date of implementation was July 1st, 1966, just about 50 years ago today. It's not widely recognized today, but it's well worth remembering that the American Medical Association actually vehemently opposed Medicare. As you can see here, they said it would be the beginning of socialized medicine. They placed ads in hundreds of U.S. newspapers trying to lobby the public and legislators, and they actually had their own plan, which was called elder care, which they touted as an alternative to the Medicare plan. Well, in order to get the AMA on board, to placate the AMA, the United States actually based reimbursement on a local calculation of a customary, prevailing, and reasonable fee. And of course, that had some unintended consequences, including the fact that the rate of increase in physician fees quickly doubled in the first few years. Physicians routinely charged the United States 2 to 4 times commercial insurance rates, led President Nixon to declare a health care crisis in July of 1969, same month that Neil Armstrong walked on the moon. Finally, about 20 years later, the Omnibus Budget Reconciliation Act changed Medicare physician reimbursement from this customary, prevailing, and reasonable charge basis to fees based on the resources needed to provide those services. A very important change. Of course, then the question comes up, who will determine what is a medical service and who will determine what resources are necessary? Well, re-entering the scene then in 1992 is the old opponent of Medicare, the American Medical Association, who at that time established a committee, the Specialty Society Relative Value Scale Update Committee, more commonly known by the acronym RUC. And this is an expert panel formed to make recommendations to CMS on the relative values of new or revised CPT codes. And really it's the process that decides who gets what of what there is to get, just basic political process. These recommendations then are used by CMS in developing annual updates to the Medicare Relative Value Scale. And although the RUC is independent, it really serves a quasi-federal role in that CMS typically accepts 80% of RUC recommendations. The RUC represents the medical profession. 21 of 31 members are appointed by national medical societies, and there's also 300 medical advisors, including now the American Society of Echocardiography. Now, this RUC committee works in close collaboration with another very important committee established by the AMA way back in 1966 called the Current Procedural Terminology Editorial Panel. This is a 17-member panel. 11 are nominated by the American Medical Association. And what are CPT codes? Well, they're the list of descriptive terms and identifying codes for all medical services and procedures. And it turns out that CPT also has a quasi-federal role in that in 1983, CPT was adopted by CMS's Healthcare Common Procedure Coding System, which mandated use of CPT for Medicare Part B. So this is a very powerful committee as well. The AMA continuously, the CPT panel continuously evaluates code change proposals which are submitted by individuals and societies and industry. They can choose to either reject those proposals or grant them Category 1 or Category 3 status. More on that in just a few minutes. So if you put this all together and look at how this works globally, the CPT process describes work. The RUC process places relative valuation on this work. Coverage is ultimately decided then by the Centers for Medicare and Medicaid Services, who issue payment to physicians and hospitals based on those entities' provision of patient care. Well, it's important to note that most, in fact, all of our medical services periodically come under RUC re-review, and there's a very important project going on right now you should know about called the CMS Potentially Misvalued Services Project. And this is my opinion, but potentially misvalued, I think, is really a CMS euphemism for likely overvalued. And how did they determine what services ought to be included? They ran what they called a high expenditure screen. They simply identified all services that cost the Medicare program more than $10 million per year. Pretty low bar. Of course, that includes really all of our services. And all of these services then were referred for RUC review. And it's important to note that at the time of RUC review, it's a comprehensive review of that service, which includes physician work, practice expense, and also a small component of malpractice expense. You may have seen ads like this at this conference, perhaps in JACE, maybe in a postcard to your home, and you'll see more of these in the future. And what it points out is a physician survey process is the key metric by which the RUC values physician work. So more on that in just a minute. What's at stake here? Quite a lot, actually. This is the Potentially Misvalued Services Project so far. 2,100 codes will be reviewed, accounting for $39 billion in Medicare spending. Still a big number. 8% of these have actually seen an increase in valuation. But as you can see, 38% so far have been devalued. 24% have maintained value. 17% of codes have actually been deleted. So a lot at stake when you go before the RUC with any of your services. Our transthoracic echo codes were actually reviewed by the RUC in April. I'm sure people in this room actually filled out RUC surveys for this code. Very robust survey result. Over 170 physicians actually submitted RUC surveys, which allowed the ASE and the ACC to make a very valuable presentation to the RUC for their deliberations. Now, coming up in October, all of our stress echo codes, both of our stress echo codes, will be reviewed. The same process holds true here. Within 2 weeks, surveys will be issued, so keep an eye on your email inbox. Many of you will receive a survey. If you do, take the time to honestly and accurately complete that. Well, what has happened to Medicare reimbursement for echocardiograms performed in the physician office over time? We know what has happened, basically beginning back in 2007, a precipitous decline, blamed in part on really a flawed RUC survey process at that time with very few physician respondents. And of course, as we all saw in our MedAxiom survey that was in our packets at pickup today, most U.S. physicians, most U.S. cardiologists now have some affiliation with a hospital, based in large part on the fact that hospital outpatient department echocardiograms reimburse at about 2.5 times the rate of a echocardiogram performed in a physician office. Of course, hospital outpatient department costs are also higher, and it's important to note that the physician reimbursement in both situations, the physician office and the hospital, are governed by physician fee schedule. The technical aspect of the hospital reimbursement is governed by the prospective payment system, an entity over which we don't have nearly as much control. Turning now to the CPT process, ASE has really taken the lead in designing and writing 3 new CPT codes for echocardiography, which have gone into effect over the last 18 months, and you should be familiar with these for your practice. The first of these is Interventional TEE, and this is just an example where we used an ASD closure device to permanently close an aortic valve in a patient with severe continuous aortic regurgitation and an LVAD. This was slightly off-label, but TEE was very useful, in fact, just instrumental in guiding this procedure, and this is the code, the new CPT code, which describes that physician work. TEE for guidance of a transcatheter structural intervention, several of which are listed there. It's not limited to those, as I just showed you. It's important to note that this code is not a monitoring code, it's not simply a diagnostic code, but rather a guidance code that more aptly describes the more intense physician work that accompanies these procedures. Now, this is a Category 1 code. It was valued by the RUC. It's reimbursed by CMS. This code went live on January 1st, 2015. Recently looked at the RUC database. This code was submitted 10,500 times in 2015. That's Medicare fee-for-service, not Advantage plans or commercial payers. And it's important because the work RVUs associated with this code are substantially higher. 4.66 for the 9 through 355 code versus 2.55 for the diagnostic code. So a 1.8 times greater reimbursement, which I think does more accurately describe that physician work. Well, myocardial strain, obviously a hot topic at this meeting. This is just an example where strain was used to detect subclinical LV dysfunction in a patient with cardiac sarcoid, but normal wall motion by visual analysis by both cardiac MRI and echocardiography. And realizing this value, ASE submitted a code change proposal to the AMA CPT panel in 2014. The panel ultimately agreed and established a Category 3 add-on code for imaging of myocardial strain to assess myocardial deformation. That code went active January 1, 2016. And so if you're performing this service, be sure to report that code, 0399T, when you perform strain imaging. Now, this is a Category 3 code, as I mentioned. Category 3 stands for Emerging Technology. And while it's not CMS reimbursed, it may be reimbursed by private payers. And ASE is working on that right now. There's also a strain code toolkit available on the ASE website that may be useful in discussions with payers. And there's also an opportunity for this code to progress to Category 1 status over the next several years if there's significant utilization and if there's additional peer-reviewed literature which substantiates the clinical utility of that service. And finally, myocardial perfusion echocardiography. Many publications now have demonstrated the efficacy of this technique for detecting viability in the acute MI setting and also for ischemia detection during stress testing. However, until just recently, there was no CPT code to describe this work. This code change proposal was submitted in 2015 by ASE, presented last October, and the panel did then establish a Category 3 add-on code for myocardial contrast perfusion echocardiography at rest or with stress for assessment of myocardial ischemia or viability. That code will go active on July 1st, 2016, exactly 50 years to the day that Medicare went into effect. And again, if you are performing this service, report that code, 0439T, if you're doing myocardial perfusion echocardiographic examinations. So just a few take-home points. The AMA CPT editorial panel and the AMA RUC committee heavily influenced CMS decision-making regarding medical services and reimbursement. RUC recommendations are largely based on physician surveys. It's critical that if you receive one of these surveys, you take the time to honestly and accurately complete it. And finally, ASE has recently spearheaded 3 new CPT codes, interventional TEE, myocardial strain, and myocardial perfusion. And if you perform these services, be sure to submit the appropriate code. Thank you.